Plagiocephaly, I always say, is kind of like a big, scary word for misshapen head. For a long time, every babe was being helmeted. The slightest asymmetry, helmet them, helmet them, helmet them. And then we went to helmeting nobody unless it was mega severe and causing some issues. And now we've seemed to have kind of crusted in the middle somewhere. Misshapen heads often come from an underlying issue. We most see it in conjunction with torticollis. Torticollis, by true definition, is, they're stuck in one position. They can't get to the other side.
In this episode, we sit down with Kelly, a registered massage therapist here at Rooted Family, specializing in pediatric craniosacral therapy and infant bodywork.
We talk about common infant concerns like feeding challenges, reflux, torticollis, and how gentle holistic care can support babies in their development while helping parents feel more informed and supported.
Hi, Kelly. Thanks so much for joining us. We're so happy you're here. We've had some bloopers already, so we're jumping right in.
Coming in hot with giggles.
I love this. That's why we're starting with giggles. So thanks for joining us. We want to dive right in because you are such a wealth of knowledge. So let's start with, if parents are kind of learning about body work or hearing about it for the first time, how do they typically come and see you for services?
With their babies.
Their baby.
Fair. Okay. Good question. Well, thank you for having me. There's a different amount of ways that people end up in my clinic space, for lack of better terms. Sometimes I get referred to them from other practitioners, whether it be pediatricians, GPs, whether it be lactation consultants, naturopathics, et cetera, et cetera. Sometimes it's social media. They posted something on there and they were like, help, and whatnot. When they get to me, usually in the infant world and the young baby world, there's an issue that's driven them there. I do have some where I've treated their first baby or, their friend or whatnot, and they just bring them in for kind of what we call as a well baby check to kind of see how things work. Sometimes I do get them into that there's not necessarily anything wrong in the moment as the parent can identify, but they had a traumatic birth per se or whatnot, and parents are a little concerned. So all different ways. As far as what I do and the idea that, oh, so-and-so, our lactation consultant said to come and see you. And I always say to them, I'm like, so somebody told you to come see me and now you're here. And you're kind of like, now what?
Now what?
They kind of, I think there's something to be said for in that new early stages, you're kind of in the fog and you're just, especially if there's an issue going on with a babe, that you're just trying your best to get through the day and to help babe out. And you're kind of like, okay, I'll sure.
And I do feel like a lot of parents might be referred or told by somebody, your baby needs body work. And then they're like, okay, but what's that?
Yeah. And they get in the door, and that's when I kind of have the same spiel. Obviously, it modifies per babe and whatnot, but my first and foremost training, oh my goodness, 2003, I'm a dinosaur, is massage therapy.
Not a dinosaur.
I'll take that.
Wise.
They say things get better with age. So, but yeah, it's my first training is registered massage therapy. I took my course and it blew up from there. So I often say I'm trained in all sorts of things. I practice contemporary acupuncture, lymphatics, though not my specialty. I do a lot of it, myofascial release, craniosacral therapy. And I said all of that to say the techniques that I tend to use most with babies and infants tend to be massage, craniosacral therapy, which does bring in some myofascial therapy as well with that too. And that usually leads to the question of, okay, now what? So I explain to them usually why I would use, let's say, massage or craniosacral therapy and why we get to those choices. So massage therapy, I often say it's lovely. It's helpful if you have a baby with a favorite side of the neck for whatever reason that they like to stay that way. We're looking at certain musculature to help them be more mobile in that. If you have babies with a latch issue, we're looking at certain musculature for oral motor to help them with that. But at the end of the day, sometimes what we find with massage is it's lovely and people will say, it was great for a few days and then it came back. My baby was all of a sudden looking to the left and it was perfect. And then 4 days later, we're back to where we started. So that's where I usually explain to them a little bit of craniosacral therapy. And I give the example of you are sitting in your house and your bedroom door doesn't shut. You take it off and you sand it down and it shuts perfect. And a week later, it doesn't shut again. And you go through this cycle, and then you have a hobbit door, basically. And you go downstairs and you pull the ceiling out and you realize the floor joist is broken. At the end of the day, until you fix that floor joist, you're still battling the same thing. And sometimes that's what we find what happens with the massage and cranial world, where, as I say, like craniosacral will go and we'll look at that scaffolding a little more closely. We're looking at all of the tissue a little deeper and the membranes and things like that to kind of get a feel for, is there a restriction going on there that can be contributing to it? So when we release that, and with some massage coupled in there, and sometimes it's more cranial, more massage, sometimes it's only one and not the other. That's obviously comes down to informed consent with the parents and kind of what the right tools for the job are in that case. And then we kind of, at that point, I usually say, like, if they're okay with it, we go through informed consent of, what an assessment looks like and why. And at that point in time, I usually explain to them both treatments as far as like any risks, complications, all the typical informed consent things that I am very passionate about, because I believe that's super important. And then from there, we usually go into an assessment, and I kind of talk them through it along the way. Assessing a baby does not look like assessing an adult. I always say to people sometimes, just don't repeat what I do in here, because we make faces, we have fun, we sing songs. You learn a little bit on the go that you're never going to get with an infant or a baby the same range of motion testing for a neck that you're going to get on somebody like you. It just doesn't happen.
Well, they
If a
don't
baby-
follow instructions. Turn your head as far to the left as you can.
And
So
we're all-
wouldn't that be easier for all of us?
right? And they don't always love being poked. And if they do have tension or
No.
pain associated with that, right? I can only imagine what their response is.
Now, I'm sure like you're kind of explaining this as you are in person with the parent and the infant or child. And you are kind of explaining, okay, massage. Now, obviously, I think the general public know what to expect with massage. Hands-on, pressure, whatever, like stroking,
Relaxation.
rubbing, lotion, But if you're standing there and you're like, oh, but there's also this craniosacral, how would you explain what
You're doing
craniosacral? What can they expect in the actual transference of your body onto the baby's body? What are you doing? Craniosacral is one of those magical mystery modalities that are still a little mysterious to people and still like, huh?
That is the $1 million question, because it is. And I say to parents, I'll backtrack one quick second on that one, just because massage-wise, it is a little bit deceiving. A lot of parents, and I do have to preface them too, because a lot of us have had massage and you're going and you're having something treated and you're going, oh my God, breathe through it. I'll be okay. You know, and if I'm massaging your neck, I can have a long stroke in that. A baby's neck is like this. And some of them who are even like this and tighter, you're literally. So I do have to preface parents and warn them a little bit that even massage looks a lot different than you or I, and it's tailored differently. I don't have the same feedback of you saying too much pressure. I do get feedback from babies and infants. We know that, right? They're actually pretty communicative when you kind of stop and listen to them. But it definitely isn't going to look like I could be massaging a baby's little neck and I might be like this. Or certain muscles on a baby, I might use a different technique than I wouldn't necessarily use for an adult, just because it tends to work better for them with where they're at. So we caveat that. Cranial. I usually say to parents, cranial, this would be my spiel. If you came in with your baby, I said, let me just preface, craniosacral is outside of the box. There's not a question. I usually say, if I was treating you as a parent, you can feel it. My hands are very light and static and gentle, but you can still feel it. Or you can tell your partner, this is what I feel. Now your baby, they can't tell you what they feel, nor can you feel what they're feeling. And my hands are light and static. So it literally looks like you're doing nothing. There are times when you do see a little more movement out of it. And there's times when you'll see like big breaths, or you'll see them get a little bit like wound up and then they kind of melt away. There are
Mhm.
some cues, but for the most part, it's fairly, I am a big humor person. I kind of, that's just my jam. It's kind of what's worked for me over the years. And I do say, some people think my broomstick is out back, and that is okay too, right?
Mhm.
I always preface parents to, one of the things with craniosacral that often really gets people through the door too, for them, is that there's really no risk to it. Like, the only risk
Mhm.
is that if it's woohoo or doing nothing, that you've spent your money. Like, that's really
Mhm.
it. There's no
Mhm.
potential to cause any issue of harm to the baby. With that said, I often say, yeah, cranial's outside of the box. It's a really tough one sometimes when we're looking, if I'm sitting there and I want to test the range of motion, I can tell you, or another practitioner, it's decreased by 20 degrees, or
Mhm.
this is this. Cranial, there's not the same tangible comparison that we have from practitioner to practitioner. I don't go down that rabbit hole necessarily with a parent, but I usually say,
Mhm.
here's how it works. The brain and spinal cord have this fluid that sits in there. It's called cerebral spinal fluid. And we have these little things in our brain that produce it. And it produces, and I give the example of a bucket of water balloons and one water balloon inside of it filling. Everything,
Huh.
it's going to fit, but everything just has to shimmy and move according to that. Well, when that shimmies and moves, there's different areas in the body that it's more noticeable on how things, and there's a rhythm happening. The rhythm is not the same as the respiratory rhythm. It's not the same as the heart rate.
Huh.
The long term, the Dr. John Eppliger, who kind of took cranial to where it is today, he did some research and along the way and stuff like that, and how he kind of discovered cranial, for lack of better terms, and went flying with it, was he was in the middle of a surgery and his one role was to do this thing with the spinal cord, and he knows there was a pulsation with it that didn't go
Huh.
without anything else in the body. And
In the
that's
body. Oh, wow.
that's how they kind of went with the cranial sacral rhythm. And basically, we have children are a lot quicker. They're more like 10 to 12 cycles a minute. Adults are more like 10 or 8 to 10. With that being said, I often say to parents, I'm looking at things like the symmetry. So if I'm holding a baby's rib cage, how that symmetrically is opening. Is it one side's opening better, or, one more shallow? The rate doesn't change for most cases. Rates changing in things like end of life. I've had a few cases I had one case of undiagnosed hydrocephalus. Um,
Huh.
so that was one that I was like, I can't get a good read on this. Something just isn't working. And I sent them back to their GP. And I'm really grateful that, I've had great success with a lot of the medical community in the city that, I don't necessarily have a tangible thing to send you back with, your shoulder
Mhm.
range of motion is decreased by 60 degrees, maybe we're up for some imaging or something like that. I don't have that with cranial, but I've been
Huh.
very fortunate that I've had a lot of practitioners that have kind of just trusted and have gone with it. All that to say, rate doesn't really change. So I'm looking for things like the symmetry, the rate, the amplitude, the quality. Is it like really like trying to open up? And all of those things tell us a story. And based on that is then how we treat, and there is one thing with cranial that happens. I'd like to say to all of us practitioners very early, and I'm fortunate it did for me, that you get something like a feeding issue.
Mm.
Somebody will say they have a very shallow latch. There's a lot of tension around the mouth and whatnot. And so, us as practitioners think, look to the mouth. The problem with that becomes is the body's a whole.
Huh.
And so you really learn to check your ego at the door and trust all the skills and the umpteen courses that we've been in and things like that, and listen to the body.
Huh.
And if you have a pelvis that's really tight and it's not moving very well and it's kind of herky-jerky on the opening and things like that, maybe there's also some muscular tension down there. Or, I do things like we call like a sushi roll, like rolling them up and feeling how that pelvis moves and that low back, for all of those reasons. Sometimes you go and release that and you don't even end up touching the mouth. And mom's like, oh my gosh, we had the greatest latch after that. Like it was game changer. And so I often preface parents a little bit too that don't get too worked up if you don't see me at the mouth today, if it's a feeding issue. We're looking at the bigger picture here, right? Like the body is a Lycra suit. We've all had that toddler that's pulled on our shirt, at a party, and you're like, what is going on? And you look down and you're like, oh, and you feel how much that pulls up here. And I say the same thing to parents. A baby's body is no different. Our bodies are no different. But yeah, and then we kind of go with it. And then I always remind parents that, if it's their first baby, I'm like, this is your fifth limb. You have the right to stop or alter treatment at any point in time. And I preface parents too that, even though we have, let's say, 45 minutes set out, babies kind of give you their consent too in a lot of ways that, there's times if they're fussy that you're like, okay, are you hungry? Is it feed me, clothe me, change me? Is it, I'm just tired of looking at your face, Kelly. and we try and work with that, but sometimes they're done. And I think there's
and they're going to let you know. They're going to be
100%
boisterous about it.
100%. And I'm also, when I trying to explain this to parents, I'm a firm believer in the short term for the long term. If I end up being this babe's practitioner, and every time they see me, they're like, oh, here comes the lady that doesn't listen. Every time, if that parent has something down the road when this kiddo's 4, I want them to have a space where it's a great relationship that they feel like, oh, we're going to see Miss Kelly. Like, it's okay. Like, she's going to listen to me. Like, that's something I'm super passionate about, that even though they're babes, they do get a say, right? And some parents look at me crazy when I look at the baby and I'm like, thank you so much for coming, sweet baby George. We're here to listen, and mom is here the whole time if that's who's in the room, and you get to go home with her after, and right. And parents kind of, I'm like, the consent is theirs too a little bit, though they can't obviously sit there and say, yes, Kelly.
Yes.
But
they can definitely feel a calm, grounded, and be seen sometimes, right? Sometimes when you really look at a baby, they see you and you see them.
Like to your soul.
Right?
Oh,
so they do that.
I think babies are
really
very
are.
humbling. I think treating, it's funny, as my practice has evolved over the years, I think babies are very humbling. I don't know if you guys see this. If we come in with a lot of baggage, like I am very science driven. Which is why Cranial kind of, if you had told me 20 years ago that Cranial was going to be something of my thing, I would have told you were crazy. I like data. I like things. And Cranial is one of those things that there's some research on it, but there's a lot of people that still believe like it's woohoo and, all this kind of stuff. But a lot of that comes from there isn't an easy, tangible way to assess something and have that studied research, 5% less, 6% more. A lot of it is parents saying, yeah, it was better. But yeah, so
the proof is in the pudding almost, right? The proof is for next visit, the parent reporting 100%. Like, oh, the latch was better, or whatever you were kind of focusing on improved.
Yeah. And I'm always the first to say too to parents that I'm like, Cranial's not the end all and be all. Like, and not everything is caused by that system. Some of it's caused from vertebral issues or gut issues or it's not the end of it. And that's where I think there's some evolution of like, again, I guess maybe 20 plus years in practice where you kind of realize that I've referred out to other RMTs before. Like it's not it's about them getting better. It's not about me being the one that helps necessarily in the hands-on. It's about overall helping this family, for lack of better terms, this triad, dyad, whatever they are at that point.
Would you say that craniosacral is your most used treatment with babes?
That's a really good question. There's days that I feel like I've done hardly any massage and I've done tons of cranial. And there's then days where I'm like, I've done hardly any cranial and I've done a ton of massage. I would say with every babe, I really try and start with a little more attention to the cranial system, just because it's such a bugger. Like if you ignore it, you just, like I say, you tend to end up in that loop. And, there'll be times when sometimes parents will come in and they'll be like, yeah, but I really want massage. Yeah. But and for understandable reasons, right? Like it's tried and true. They felt it. They can see it. And you go as a practitioner, you're like, okay, let's meet them where they're at and do it. And then you kind of are like, dang it, we're not like, you just know. And I'm sure you guys know this, right? Like where you go in and you have a chat with let's say a mama, and you're like, there's just a little more to this story here. There's something else that's a piece to the puzzle. And then, sometimes, and I'm really appreciative and I'm grateful that, sometimes there just comes a trust switch, from the parent that's like, you know what, let's go down that path today. And I'm like, hey, if you're comfortable with that, let's try it.
Yeah.
And then you're kind of like, aha. So I wouldn't say it's the only thing. I would say it ebbs and flows. I'm doing a lot more like oral motor these days too. So we're getting into a lot more latch from like looking at how the tongue moves and things like that. So with that case, yes, there's still a lot of cranial to do with the mouth and whatnot, but a lot of that tends to be some massage too. Yeah,
How does
that's a
that
tough one.
Let's talk about feeding, because I think that, I mean, that's obviously a big component of your work and also the referrals from lactation consultants. How does the tension like present itself? So if a parent were concerned, like didn't know, what would be signs that they would be looking
Oh, that's a good one.
for?
I don't know if I can answer that with one small summary.
Like its own podcast.
Isn't that the way, right? Because we could sit there and we could talk about like latch being something about like a traumatic birth. It could be a vacuum delivery. It could be forceps. It could be, it could be latch because they've got reflux and they're like uncomfortable. It could be latch because of colic, which we can go down that path. It could be latch because of like, gastro issues of like too much gas. Like there's so many, it depends on that one.
Tongue tie, lip tie,
100% oral ties.
It is often then
buckle ties.
this tension though, right? Like, is that what you would kind of?
It's, what, usually I would say latch comes down to a few things. Like first off, I always say to people, I will never judge how a baby's born. At the end of the day, everybody in this community and everybody in this, I'm hopeful that everybody in this world, at the end of the day, everybody's goal is the same: happy, healthy baby and mama who's or delivery, whoever's delivering. That's ultimately the goal we all have. So at the end of the day, I trust that whoever's in that room is doing the best they can to get the baby here. With that said, sometimes that history makes an impact on things. So if you have a babe who was maybe a vacuum birth or sometimes forceps, right? Like forceps, when we look where they're trying their best, but let's say they slip, or at the end of the day, again, they're made to be a guide, but sometimes, again, I don't condone it, but I trust that sometimes they have to maybe pull a little bit with it and stuff like that. And that's just where they're at in that birth, right? You and I and nobody else, will never be there to know, and it's not my job to criticize. It's my job to, what's in front. So oftentimes with, all of these types of things or oral ties, there tends to be tension in through the area. That tension can look like different things. It can look like neck, where they're like, baby only looks right and doesn't want. So in that case, we're looking at like, I get sometimes from lactation consultants that baby feeds really well on one side, but doesn't the other. Or
that's a very common one.
Huge. Or even not even that association. Cause we forget too that, I mean, and Christine, like you know this from your classes and stuff like that everybody talks about that, the pregnancy and the delivery. And then it's kind of like crickets for that fourth trimester a little bit, right?
Not in my class.
And that's where I'm grateful for people like you guys that are changing that. And like I had a lovely naturopath for my pregnancy and stuff, and she's like, you're gonna stop and you're gonna start looking at the fourth trimester now. She's like, stop reading delivery, stop reading this, look at that. And I'm grateful those of you guys that are changing that face a little bit, because oftentimes mamas, if it's mom that's breastfeeding, we just expect that they come out, they latch on, and all is kumbaya, and we're great, right? Like there's nothing more. We're feeling great, and
that's what just happened.
And that's and I would say, I don't know, I don't have a statistic off me, but I'm going to say that's maybe 30% of the population, right? That it comes off and it works perfect. So a lot of the times when we're having feeding issues, it's not necessarily even parents saying that they feed better on one side or the other. It'll be something like, oh, my left nipple is super cracked. Or it'll be a sign that my right breast doesn't produce as much. And I'm like, okay, now I'm looking at like, what position are you using to breastfeed? Well, this side I use cross cradle and this side I use football, or things like that. I'm like, okay, so not all the times too does it always come about in the same way that we think it will, right? And I think as a breastfeeding parent for a first time, I don't know, we're all kind of flying a little bit in the wind sometimes. You think you know it, you've read all the
Survival.
books, which is why often it's funny when mamas come in pregnancy, or I talk to them, or you see it on social media all the time, and they're like, what pump should I put on my registry and things like that. I'm like, breathe and pause. Your first stop is a lactation consultant. And they're like, but I don't have the baby here. I'm like, this is the perfect time, right? Like, go see that LC, find out from them different positions, what to look for. Obviously I won't go down that path. That's an LC role, but different pumps have different purposes, and some
They
are
do.
helpful, some are hindering. And, it depends on, and maybe you don't want to breastfeed, but hey, instead of buying $300 in bottles and nipples, and then the baby gets here and you got to buy $300 more because that 300 didn't work. You have a meet with them before.
And then clearly there's so much that comes into your room, not just what the babe needs at that moment, because you might be the only care provider who is actually spending 45 minutes and all the questions are going to come out. So you become a little bit of the information provider for so many things regarding babies and children and infants, right? What is the biggest maybe questions, or the biggest information seeking things that parents come into your room with?
How do I answer that one? It's honestly, there's everything. I think, you know what? I think silently a lot of, I'm going to use the word mamas here because I tend to see a lot of the deliverer, in the room with the babe.
The birth giver.
The birth giver. Thank you. You know what? Like, a lot of it is like help in all facets. And then I think there's a trust that kind of becomes, and I'm so grateful for that then all sorts of questions start rolling. But I think one of the biggest things is it's okay not to know. Like, they don't come with a manual.
You're not supposed to. Yeah.
No, and some moms will be like, I should know this. I had another baby. I'm like, yeah, but you and your sister are nothing alike. Like, I look at my 3 kiddos and I'm like, I can't parent, my 15-year-old the same way as I did my 19-year-old. They're completely different humans. And I'm like, that's the same as for babies, right? And so I think a little bit of, if you're really saying the word seeking of like what they're seeking to know, I think, yes, a knowledge about how they can best help their baby. Number one, 100%. Mamas will throw themselves off, off to the side for the baby. We do have to have that conversation, which sometimes is easier than hard. That like, that age-old that adage of like, the oxygen comes masks down, come in the airplane. You have to put on your own before you can put on everybody else's. And I'll say to mamas sometimes too, it's okay. Like, if you have what we would coin as a colicky baby or, whatnot, it's okay to, put them down, make sure they're in a safe spot in their crib, let's say, go outside, scream into a pillow, do some jumping jacks, come back in and, feel a little bit of a reset, because whether we can explain it tangibly or not, like, we know that we feel things, right? Somebody goes into a hospital and their blood pressure spikes, we call that white coat syndrome. That's just a feel of consciousness, right? Like, at a certain point, there's got to be that link that we acknowledge there with mom and baby. And then I think the second piece comes to is just, once we've kind of said, okay, yes, let's try our best. And I always say to parents, I might not be able to solve this, but I'm darn well going to help you get to the person that can make this better for you. I don't promise that we can solve it, because sometimes I don't know like what it is.
For sure.
And sometimes there are bigger issues. I'm not going to lie, right? Like, I feel privileged to have been along some pretty crazy paths with some parents and families, but at the same point in time, some of those paths led them to surgical and, umpteen hospital visits and stuff like that, because we've discovered that there's something bigger going on than just a body tension, for example. But I think mamas, needing to be heard and being heard to listen to, of like, take a breath and come back to those instincts. I say there's nothing
Mhm.
like mama instincts, like,
No.
Yeah.
like,
And I
um,
feel like they do get a bit more of a package deal when they come into your room because
mm,
practitioners who pause and stop and look
Mhm.
at the whole picture get more of the story.
Right.
and you try, like, and I'm also grateful, like, obviously, we'll go to you guys for a minute. Like, you guys have created a space. I've had times where I've had a mom, and I again, very grateful that they feel safe enough in that space to, I always look and say, and how are you feeling? If I have a
Mhm.
mom, and when I look at it from my scope of practice style too, if I have a mom who's got a wrist issue on the right and she's got mother's thumb or something that's happening, right? Even though I'm there to treat baby, well,
Mm.
now I'm looking at, oh, is she only holding baby on the left? And does that mean baby's only ever looking that way or something like that?
Mhm.
That's part of the puzzle too,
Ties
right?
in for sure.
You can't ignore it, right? And so when I ask
Mhm.
mom, how are you feeling? Sometimes I get, I'm fine. And again, here's where I try and meet with humor. And I'm like, is this an I'm fine, like I'm fine? Or is this an I'm fine, we're all fine, we're fine, we're good, fine? You know,
Fine, fine. Everybody's fine. It's
you
fine.
know,
Covered up.
and
Covered up.
sometimes they'll be like, I'm fine. I'm like, okay, let's go with that. You're fine. And sometimes they're like, I'm not fine. I'm like,
Mm.
okay, let's talk
Mm.
about what can I do to help you be fine? Because again, I'm looking at, in that case, like the dyad that's there in front of me. And
Mhm.
and I'm grateful that, there's been more times than I can count where, where I'm in a treatment space where I can kind of walk down the hall and possibly snag a mental health practitioner and say, hey, what do you got in the next 24 hours that you can help me with?
Mhm.
And we've been able to have a mama be seen and talked to, and,
Mhm.
Mhm.
or, I can walk down and say, hey, to physio or chiro, or use some of my external resources too, right? Of saying, like, what else do we have? Do we have a person that can, like a postpartum
Mhm.
doula that can go in that home and be
Mm.
like, this mama's like, my partner's traveling or whatever. I just need sleep. And I'm like,
Mhm.
okay, because at the end of the day, if what's best for babe is us to see them next week and mom is now sleep deprived for the next week and a half, and I'm asking her to get in her car and drive there too, trying to meet them where they're at, I think is a big piece. But I
Yeah,
think
there's
mama,
just so
yeah,
many layers, right? They've
Mm.
come in for
yeah,
one thing, but
yeah,
then other things can get, right?
Mm.
And if you're
Yeah.
asking about how the birth
mhm,
went, which may be a contributing factor to what's going
mhm,
on,
mhm,
Mhm.
now you're asking a birth giver to talk about something that might not be processed yet,
Yeah.
or it
Mhm.
gets
yep.
processed in your room.
There's a lot of tears, and mamas are
Yeah.
always the first to say, I'm so sorry. I'm like, listen, we could buy shares in Kleenex at this point. Like,
Yeah.
you are not the first, you will
Bring it
not be the
on.
last. And let's go. And sometimes it's just kind of talking them through too how to self-advocate. If they've
Mhm.
been to a practitioner and they don't feel heard, or their partner, or
Mhm.
we see some cases now with multi-generational living or just grandparents in town. And I'm like, trying to be like, okay, I have to recognize I have to stay within my scope. So I try and always keep that very tight in mind. But
Mhm.
hey, why don't we get you to the person that can help you get that foundation?
Mm.
Or,
Mhm.
yeah, you are seeing a head shape change.
Mm.
As a practitioner who sees babies all day, maybe grandma or grandpa who might have the greatest intentions that might be like, no, 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 it's fine. I'm like,
Mhm. Yeah.
maybe let's put you back to your GP. And I encourage parents to take pictures for themselves to keep of like their babe. If they do see an asymmetry and things like that, you know what, you can then go to your GP and say, hey, look at these 3 pictures. Like, I think
Yeah.
it's getting worse too.
Mm.
And sometimes that,
Right.
like they're not wizards either, in the sense of, like, as much as we'd like us all to be, you know, they can't track everything, right? They're with us for maybe 20
Mhm.
minutes out of a visit, maybe less, maybe a bit more.
Mhm.
So to be able to, kind of help self-advocate too and be like, no, you're on the right path. I think you got it. Like,
Yeah.
how can we make this work easier for you? So when you do have that GP appointment in a week, or there's sometimes I'm like, we need that
Mhm.
appointment a little
Mm.
sooner. And again, I'm grateful for the medical community that
Mm.
really I've had a great relationship to be with. Okay, yeah, there's something, you're being referred back here. Let's try and prioritize this.
Can we
Yeah.
talk about head shape then, since you brought it up? Let's talk
Yeah.
about
Mhm.
torticollis.
Mhm.
head shape, because I think those are also words people hear. So they're in that, like you said, the sleep
Yes.
deprived, like that, those first couple of weeks, and then they hear the word torticollis or
Yeah.
head shape.
Plagiacephaly.
Yes.
Okay.
So I
Big
always
word.
exact and now you know what I say to that? And now keep in mind I'm talking to parents. Like I've had a few instances where I'll explain things in kind of like parent to parent with no medical background. And then like mom will be like, oh, yeah, I'm a cardiologist or I'm a neurosurgeon. And I'm like, oh, okay, I
Oh.
probably could have given you a different version. So keep in mind, like a lot of my explanations try and come with the merriment of like where that parent's knowledge is or that person's knowledge is. But plagiocephaly, I always say, is kind of like for parents, it's a big, scary word for misshapen head, at the end of the
That's it.
day. Like that's essentially what it is. And so I say, what you need to know is that, the babe can have a misshapen head or an asymmetry. Again, keep in mind, like I've been doing this for over 20 years. And I'm sure as like all of us, right? You see the ebbs and flows of where we are. Like we try to go one side of the spectrum, then we end up on one, and then we kind of end up somewhere in the middle. And, for a long time, every babe was being helmeted. Like we were helmeting everybody. Just there was the slightest asymmetry, helmet them, helmet them, helmet them. And then we went to helmeting nobody. Unless it was mega severe and causing some issues. And now we've seemed to have kind of crusted in the middle somewhere. Obviously, the era of technology has advanced is huge, right? Like now it's no longer just measurements with a, tape. It's, scans externally and stuff like that, and 3D printed helmets that it's crazy to see. When I first started this, a helmet, it was like a huge ordeal and all this. And now you like go in and there's a new 3D printed helmet, like done, like not on the spot, but way quicker than we used to be.
Very customized.
Yeah. Misshapen heads often come from an underlying issue, right? That we most see it in conjunction with torticollis. Again, torticollis, by true definition, is, they're stuck in one position. They can't get to the other side. Realistically, what we see mostly is a preference to one side, where babes they'll go to this side, they'll go to this side. They won't go the full way, but they'll experiment with it and they might not love it. And then they'll just favor to the right. So most will, and if you do it passively and move them through that range of motion, you can usually get them through it fairly easy. They just don't, and you'll feel it. You'll feel in massage world what we call like an end feel. It'll feel a little more sticky and a little bit more restricted and tense and whatnot. You do get some where, true torticollis, where a muscle is in spasm and they just can't. Most adults have woken up at some point in time in their life in the morning and they're like, I can't move my neck.
What's wrong?
It happens for different reasons and things like that. We do tend to see, and this is go ahead.
No, I was going to say, so there is a slight difference. So sometimes there's just restriction. And then other times there's actually like some muscle spasm going on.
Yeah, you can have a really big spasm where they physically can't go, or you can have a vertebral issue, right? Where no matter how much they go, it's just locked, it's stuck. They cannot go. So true torticollis is where they can't go. You will not, they will not, you can't, they can't, if not. Most of what we see with infants is more of a favoritism than true. But for ease of words, we tend to say torticollis. Just to kind of keep things simple and streamlined. With that said, neck preference can come from a lot of things. We generally only see plagiocephaly and head shape changes when there is that. You do see it if it's flat, right, straight on the back. Babes who, for whatever reason, are more laying on their back. Maybe there's multiple kids in the family. Maybe, babe just has to be, for whatever reason, they're in their car seat more. This is the era where I try and talk to parents about, let's get them out of that car seat. And, when you do go for the ride, if they fall asleep in it, if you get home and you're watching them and they're going to sleep for another 5 minutes in it, okay, fine. But if they're just started their nap, let's try our best to get them out and get them off that back of their head for so much. Just from a prevention standpoint, more so than anything. I mean, we can go down a whole nother path of airway and car seat and all that kind of stuff, but that's a whole beast in its own. But all that to say, so there is times where you do see head shape change when there is no neck favoritism, but it's not necessarily the bread and butter of what we see.
Are they born with that, or is it typically because they're lying on that side mostly?
Really good question. It can be a little of column A, column B. If they're born that way, it's usually, my experience hasn't been as much. Born head shape changes are usually like where we see kind of like the torpedo head or things like that. In my brain, I call it the torpedo head when they're very pushed back. Some of that you see like born like sunny side up versus whatever. Like you'll see things like that. But you generally, from a birth, more often than
But
not, you won't
multiples
see.
also, multiples
Yeah.
can misshape each other's
Yes.
heads.
Yeah. Or that's what I was going to say, where I was first going to say too, is that like, if you'll hear them, like mom will be like, oh, they dropped really early and they were off to one side. But with that misshapen head, if they've been down there for like that for a while, and same thing with multiples, often there's usually a neck tension too, because they've been like this for last 6 months trying to share what little space is left, right? Or they're down shoved against like the pubic bone and they're kind of like this. And also too, this goes back to mom or the birthing person's prep too, when they're pregnant and stuff. If you have things like pelvic rotations in the carrier, then all of a sudden now the babe might not sit there. I mean, and again, you could go down the delivery impacts of that and whatnot, but all that to say there's a lot of factors on that. So yes, so neck preference comes from a few issues. Tension is the main one. Where the tension is from is the next story. There is some research out there that's showing a link between oral ties and neck preference because of the tension, right? Ultimately, whether that tension is because there's too much tissue there, whether that's the tension because the tissue being excess and less range of motion allows other things to tighten down. Potato in my eyes. It's just we gotta fix it, right? Like people will say, oh, some chiros will believe the joint goes out and the muscle compensates, or massage therapists say the muscle pulls the joint out. And I'm like, at the end of the day, I don't really care which is happening. Let's just fix it. Like,
let's fix it.
If that's going to be us and Cairo, like, sure, like we'll figure it out. Like, I don't need to be, yes, it's because of the massage system. No, I don't care. If it's a factor, I shouldn't say I don't care. If it's a factor that the muscle's constantly pulling at the vertebrae because somebody is constantly looking one way, okay, we got to talk about things. Yes, I care. But at the end of the day, it's about fixing the issue. So there is some stuff coming out there with oral ties and neck favoritism. There's also a little bit of poking around that you'll see reflex, oral ties, and neck. All three of them. It's not uncommon to see them as a combo.
Right.
I think I think as we get more aware, it's interesting, 10 years ago, moms would be like, they'd show up and, they wouldn't understand anything about their diet impacting babies, feeding and stuff like that. And it's not my scope to go down that, but it's my job to recognize like, hey, if I think there's somebody else that could help them navigate if that's a potential issue. I would say information is knowledge, right? Like,
well, and I do feel like that's when the holistic care comes in. Again, just kind of looking at the wraparound care of the different layers, where if parents really only have experience seeking out a medical provider, and thank goodness we have them, and no qualms, but tying in the layering pieces and accessing care of other people who probably work with the babies more than your general practitioner does, right? They're leaving all the eggs in one basket for finding answers. I feel, obviously I'm a little biased to our multidisciplinary wraparound care, but this just goes to show that someone as experienced as you is going to be like, you need to go talk to that person because that's not my scope and it's not my expertise. But I just love that people can come and get answers at different levels and look at all the layers that you offer.
And it's true. And I think people understanding that layers are key, right? Because, I could have a babe in front of me who is throwing up constantly, right? And uncomfortable. And I can't diagnose. That's out of my scope of practice, and I don't. But I'm thinking, oh, okay, this is some possible reflux here. I'm not saying that to the parent, but this is kind of like, it's kind of fishy there. Oftentimes the parent will ask me, is this reflux? And I was like, well, it's not mine to pinpoint, but I think you might be sniffing up something, that your spidey senses might be onto something, right? Like, and sometimes what we'll have is that dynamic of, sometimes I get people through the door that are very holistic and they do not want Western medicine at all. And
Right.
some people that are the opposite, they don't want holistic, but they only want Western medicine. And it's trying to find that common denominator for them of like, there is a place and time for everything at some point in time for the most part, right? And, sometimes I'll say to parents like, hey, why don't you pop in and see your pediatrician or your GP, whoever they're with, and have a conversation, like get some data, record some stuff, like how often they're throwing up, take pictures if you want pictures. It's so easy to describe poop to a GP, but when you show them a picture of it, it's a whole lot different. And go back. Maybe there is a place for, some meds for a bit while we get some other things under control with tension in the body and stuff like that. Maybe there's not, like at the end of the day, it comes down to informed consent, or maybe there is some place for that if baby's weight's dropping and mom's trying to figure out diet and stuff like that of what she's breastfeeding that might be impacting things. It's all in those places. And I always say to parents, like, information ultimately just is knowledge, right? Whether you agree with it or disagree with it at the end of the day, it's information that you have to make your informed choice on. And, and again, like I have to stay in scope of practice, but, like sometimes they'll be like, yeah, I'm like, yeah, pop back in, talk with your GP about that. That's all. So it seems like a lot of vomit, like for that area, and they're kind of uncomfortable. So why not go and check that box and see? And parents are like, well, I don't want to be on medication. I'm like, you know what though? It's not about being on it or not being on it. It's about keeping that open communication with that GP and getting the knowledge that they have and that they can bring to you that, maybe they'll be like, it's not reflux, it's this. How about you change this or this, right? And
Well, I think it's just better to offer all the options so that they can make a decision.
100%.
Well, what is reflux, though? I guess like bringing it back to I think we're talking about terms, but so reflux, colic. Maybe let's go there.
Oh, I know. Okay, so again, keep in mind I'm a dinosaur. When I was in school, colic, true colic, was taught to us by its an immaturity of the bowels. So basically, then what it was thought was that whether it be a preemie or just a babe, for whatever reason, their bowels were just taking a little bit. And they used the example for us of what we call peristalsis and how like that muscle contraction moves poop and gas down the intestines and helps it gets out. And newborns and some preemies and whatnot, that they don't have that muscle development the same way, some of them at that time, and that goes. Now, fast forward to now. Colic is defined as very different, right? Like a lot of cases, you'll see the 3-3-3. So they cry for more than 3 hours a day, more than 3 days a week, lasting longer than 3 weeks. I think that's John Hopkins, I think, puts that out. I think is there. Don't quote me on that, but them or the Mayo Clinic, one of them. That's kind of their definition of it. At the end of the day, if somebody comes in with colic, a colicky baby, they're usually defined by being fussy.
Their definition of colic.
Yeah, their definition is usually being fussy. And this is where we do define it in the medical world now. It seems to have kind of gone to that catch-all diagnosis of fussy baby, maybe tight abdomen, red in the face. They're clearly not happy. Again, crying for 3 hours a day that we cannot solve. And I mean, most parents are going to try all those typical tricks to solve. You've changed their diaper, you've fed them, all of those types of things. So at the end of the day, it's that unknown piece. Right. So if a parent comes in with, is this colic or could this be colic? Or I've told this is colic and that you can help with body tension. I always say like colic is okay, it's the word, but at the end of the day, I'm trying to figure out why are we fussy? Most, you or I don't wake up wanting to be grumpy. And I kind of have the firm belief that neither does a baby. Like,
Mm.
like we don't wake up wanting that. It's our expression of something. Maybe we didn't get enough sleep. Maybe, our kiddos are bothering us about, can I have the car again for the 15th time that day? For whatever reason, there's usually an underlying cause. And I look at babes, a lot of the similarity on that, okay, colic might be over here because this is what they've been labeled with, not by me, but just by somebody.
Mhm.
But
Mhm.
what are the symptoms? What has gotten? Tell me
Mhm.
your story. Oh, and then
What
sometimes
makes
they
you
get
think they have
yeah,
colic?
like what?
What is
And I
your
always
definition?
yes,
Mhm.
and I always say to parents,
Sure.
right? Like I'm not here. I don't care if you feel it's colic. That's not my judgment. That's it. But what got you to that? And sometimes
Right.
it'll be, oh, you know. This practitioner said that, or sometimes it'll be, my
Mhm.
sister-in-law her kiddo had this.
Mm.
And I say, okay, tell me the symptoms. What, and they'll say, oh, I can't put them down to sleep on their back in the bassinet. And I'm like, oh, okay.
Hmm.
Ting. First thing goes off. And they'll be like,
Mhm.
oh, they're really, really, they latch on, they latch off, they latch on, they latch off. I'm like, ting, and now all of a sudden I'm putting the pieces together. I'm like, there seems to be some sort of feeding thing going on here. Like if it's a dietary thing of maybe there's like a sensitivity to something that, again, that comes out of my scope, but that's where I'm saying, hey, how do you feel about checking in with your GP about maybe, some of this, B with maybe the lactation consultant to make sure that there's nothing with like a oversupply or something like that going on there, your naturopath or, whatever realm of that side that you go with to see if there's anything there that they can do to impact this,
Mhm.
or if they're coming in and they're saying, oh, they have a really hard time farting and they're really uncomfortable and it wakes them up and they high pitched scream and squeal. And I'm like, okay,
Unfortunately,
let's,
I feel like so much of these symptoms that parents are coming in with, unfortunately, is just kind of some normal newborn behavior,
Mhm.
right?
some of it
But
is.
without them kind of knowing what's normal, how
Mhm.
can they classify whether it's a problem or
Mhm.
not,
Mm.
Mhm.
right?
It-
Like,
And
there's
and
so
I
many parents who are like, "My baby is so
mm.
gassy." I'm like, "Okay, well, so are you. You
Mhm.
probably fart about 15 times a day.
Or they'll say my baby's so
Humans are
gassy.
gassy."
And I'm like, what did you have for dinner last night? And they'll be like, I had cauliflower. Oh, cauliflower
Yep.
makes me
Oh.
so gassy. And I'm like,
Yeah.
cauliflower might make them
Oh.
gassy too.
I
And I
was
always say
I was
that's
that's normal, but I
Yeah.
was supporting a
Mhm.
family and I got to her and she's like, 2 days screaming nonstop. I have a colicky baby
Mhm.
Mhm.
because obviously she's Googled a baby
Yep.
crying
Of course, a
and
fussy baby. Mhm. Mhm.
Yep.
and I knew that this baby was primarily fed from her body, breastfed. I said, "What did you have for dinner 2 nights ago?" And she's like, "Chili." I'm like, "And what did you have for lunch yesterday?" "Chili." Because somebody came
Brought
to
chili.
this new
Lovingly and brought
mom with all
chili.
of this. "And what
Oh,
did
I
you have
love
for
it.
dinner last night?" "Oh, chili." I'm
And
like,
it starts to go, eh?
and then
Yeah.
they're like, "Wait." So a colicky baby is a baby who is expressing
Mhm.
something in their body that is
Mhm.
making them uncomfortable.
Yeah.
Oh.
Yep.
And for someone to just pass it off and say, "Sorry, your baby has colic," it is typically an underlying something. Like another mom I know went to CHEO twice with a screaming baby, and CHEO sent her home and said, "You have a colicky baby." With about an hour-long conversation, we figured out that she just wasn't transferring enough calories to this baby.
Mm.
Her baby was
And
very hungry.
Right.
And this is where it comes into the next piece too, right? Another
Mhm.
piece for me. Okay, let's say it truly is a colicky baby and that's what it is. I'm also not going to be like, go out into the world, live your life with a colicky baby,
Yeah.
because
Wait for them to be better.
that's where you
Mhm.
get that paternal breakdown or
Mhm.
that maternal and paternal breakdown or that parental breakdown is what I'm looking for.
Mhm.
That, sometimes I think we like that box definition of colic, for example. I'm just using that as an easy example
Hmm.
because it's easier for, I'm going to use the term mamas, it's easier for mamas to feel when they just have a fussy baby, it's almost sometimes you see mamas go, well, I'm
Oh,
not
it's
meeting my
colic.
baby's needs. And then they
Right.
start to
Mhm.
cycle on themselves of like, I'm not good
Mhm.
enough. I can't do
Mhm.
this, or,
I
or,
can't figure it
Susan
out.
down the road is just being like, it's okay. It's okay. You'll figure, you're
Mhm.
fine. You're fine. You're doing great. And I'm like, so I think sometimes when we get that definition, it gives mamas a little bit of a, oh, they have colic. It's them, not me, right?
Right.
And so I
Mhm.
think too, if you do have a colic instant, it's also meeting that mama where they're at in the sense of like, it's okay, like, and
Mhm.
it's okay to feel frustrated and it's okay to feel those things. And there is other supports out there for you to get through those, for whatever. And then it's our kind of job to siphon through being like, okay, now what is the issue? Let's go down. If it is a true colic thing, I'm not going to send a mom home and be like, there's nothing I can do for you. I'm going to be like, let's figure out like, hey, how about we get you treated? Or let's figure out like, how can we make the baby just a fraction more comfortable? And then how can we have that mama have the resources that she's going to need, whether that be some in-home help, whether that be, hey, why don't let's find a walking group in your region, or, hey, what about some mental health support, baby cafes, we obviously have one, but there's multiples throughout the city too of
Play
like,
groups,
y-
yeah.
you know,
Get together with
what's,
other moms, get out of the house. Yeah.
yeah, where's that support that we can still, not just like, yeah, it's colic,
Sorry, wait
like,
for a
You're
few months and then it's done.
yeah,
Yeah. Like your baby
and
doesn't want to be put down. Let's teach you how to wear your baby so that you can
uh,
kind of keep going. And your
Yeah.
baby doesn't have to be put down until we figure it out.
100% find those mediums of like, how
Yeah.
can we work within the framework of what we have, right? And you'll get that in all different facets with parents. Like I'll say, I often very forward with parents, like when I'm giving homework, parents are lovely. Some of them are eager, some of them, but I think as a practitioner, there's also, and working in this world, there's also an element of trying to step back to and see where they're at that time. And I'll say to parents, like, if I've got a parent who babe just had an oral release and they're doing tons of neck or tons of stretching in the mouth and all those types of things, and I go and add on 5 more stretches, like now nothing's getting
Overload.
done, right?
No.
It's just too much. And so sometimes and I'll say to parents, I'll be like,
capacity.
100%. And meeting them where they're at, right? Like of being like, if this mom already feels like she is not getting through anything and I give her one more thing, she's going to be like, that's just one more thing I can't do. And, so sometimes I'll say, listen, I'm very forward with all of my clients. I'll say, if there is something that I feel like you need to do because we're dealing with a neck range or we're having like, let's say we're on the failure to thrive path or whatnot, like I'll say, no, I need you doing this. But often I'll be like, listen, this would be optimal. If you get it in once a day, awesome. If you don't get it in for 3 days, it's okay too. Like it's not going to. And I always say to them on the flip side, I will tell you if I'm like, no, this is make or break. I need you on this. Right. Like it's about kind of finding those balances of where they're at too.
Well, and every family is just going to have a different plan of care for
100%.
their needs,
Yeah, I think we're really fortunate in Ottawa. We've got a great group and it's I think there's a lot of parental support out there. It's just it's about, meeting parents where they're at and helping them find the best guidelines for them, for baby, for, the family and
what's needed.
dads too. I say to dads too, I'm like, that ain't
Partners
easy.
are,
Or
For
partners
sure.
in general, just because you didn't birth the babe, none of it's easy, I'll also, I think we're going to link, I'll link the Upledge Institute, which is where I took my cranial training through. There are some other ones around, but he's kind of like the granddaddy. So yeah, they've got some research on there and stuff like that. They're obviously a major institute, so they're going to have a lot of that stuff on it.